Hey, BC here for BC Nephro. Thanks for watching. Today I'm going to talk about solitary kidney, living with one kidney. So we're going to talk about what are the reasons why someone may only have one kidney, a solitary kidney, what is the expected kidney function with only one kidney, and what are the long-term potential risk complications, things to monitor for. For more information, check out bcnephro.com. Link will be in the description below, and also check out the videos at this channel. Now let's get into it. First, what are the reasons why someone may only have one kidney, a solitary kidney? These can be broken down into congenital and acquired. So the congenital reasons are renal agenesis, one kidney didn't form, renal aplasia, one kidney didn't develop, and multicystic dysplastic kidney, a non-functional kidney developed. So these are the congenital reasons. Acquired reasons would be someone requiring a nephrectomy, kidney removal. This may be because they are a kidney donor nephrectomy. This may be the kidney may need to be removed for malignancy, cancer, angiomyolipoma that's large. Kidney may need to be removed if it is chronically dysfunctional and causing a complication. So an example of this might be a chronic obstructed kidney that is also chronically infected. And then there is a possible traumatic injury that could require nephrectomy. Next, what is the kidney function if you only have one kidney? So it's reasonable to assume that if you remove one kidney, if you only have one kidney, you have 50% of the kidney mass, you'll have 50% of the kidney function, though this is not necessarily the case. It is true that the number of nephrons that one is born with is fixed. More nephrons cannot develop after birth. Although if someone is born with a congenital solitary kidney, that kidney may have developed more nephrons than typical in utero, but after birth, the number of nephrons is fixed. However, these nephrons can hyperfilter and compensate for the decreased renal mass, and this hyperfiltration will be manifest on imaging with an increased kidney size, so the ultrasound will be able to see this compensatory kidney hypertrophy. So the expected kidney function really depends on if the solitary kidney, the kidney that's the remaining kidney, is normal. So in the cases of a donor nephrectomy, kidney donor, the remaining kidney is by definition normal. When it's studied, what happens is this: the solitary kidney increases its GFR to 70% of the pre-surgery, pre-nephrectomy 2 kidney GFR within 2 to 3 weeks, and long-term the GFR is 75 to 85% of what the pre-nephrectomy 2 kidney GFR was. Likewise, if someone's born with one kidney and the other kidney is normal, that other kidney would be expected to maintain a GFR, although maybe not completely normal at 125 mLs a minute, to be in the normal range, and it would be expected to not have chronic kidney disease. They would expect it to have a serum creatinine GFR in the normal range. However, in all cases, the remaining kidney is not normal. First of all, in cases of a congenital solitary kidney, there's a higher incidence of concomitant congenital abnormalities in the remaining kidney. About a third of those patients will have another congenital abnormality in the solitary kidney or urinary tract, and these patients would be at a higher risk of developing chronic kidney disease, a decreased GFR in the pediatric setting. Likewise, patients who require a nephrectomy for a diseased kidney or cancer or older, the remaining kidney may not be normal, and my assessment in these cases is that the remaining kidney, if it's not normal, would not have the ability to compensate. So if these patients have chronic kidney disease, a decreased GFR with 2 kidneys, by definition, the remaining kidney is not going to be normal, because if it was normal, it would be able to achieve a normal GFR of 75 to 85% of a 2 kidney GFR by itself. In these cases, one might predict a post-nephrectomy kidney function GFR to decrease by 50% after the removal of the kidney, although this is not always the case either, because in these cases, both kidneys may not be contributing exactly 50%. The kidney that is to be removed might be diseased, it may be contributing less than 50%, although in some cases, unfortunately, it may be the better of the 2 kidneys and may be contributing more than 50%. This is determined by a split renal function scan. A split renal function scan tells us the percent of the kidney function that is coming from each kidney. It does not tell us what percent each kidney is working, but the percent of the kidney function that's coming from each kidney, and that may not be 50%. So what I do is take the results of the split renal function scan. Let's say in our case, the remaining kidney has 60% of the kidney function. I multiply that 60% by the pre-nephrectomy total GFR. If it is if the patient has chronic kidney disease, the GFR is below 60. So let's say in our case, if the GFR is 60 and the remaining kidney has 60% kidney function, I would anticipate the post-nephrectomy GFR to be approximately 36, which would be a higher stage of chronic kidney disease. Next, what are the long-term risks? What are the long-term complications of having a solitary kidney? As we just discussed by the prior example, if someone has chronic kidney disease at baseline, they're likely going to have a higher stage of chronic kidney disease post-nephrectomy. Otherwise, the kidney function is maintained by hyperfiltration, but this hyperfiltration may be maladaptive and lead to glomerulosclerosis, which can lead to proteinuria and chronic kidney disease in itself. In a congenital solitary kidney, although that kidney may have increased nephrons, more nephrons than typical for a kidney, they have hyperfiltration by definition for a longer period of time, for their entire life, have this risk of hyperfiltration and glomerulosclerosis. Patients with the healthiest remaining kidney, patients who donate a kidney, donate a nephrectomy, do have a slight incidence of a slightly higher blood pressure. On average, maybe the systolic blood pressure is 6 higher than controls. They also may have a slightly higher urinary albumin excretion. And although patients who have a donor nephrectomy have a very low incidence of developing kidney failure, low incidence of developing end-stage kidney disease, lower than the general population, as this is a healthy subset of the general population, the risk, although low, is slightly higher than it would be predicted if they didn't donate and had 2 kidneys. Other potential things to look out for a solitary kidney is, first of all, kidney stones. If the solitary kidney does have kidney stones and that kidney stone passes, they could develop acute kidney injury. In normal situations, if a kidney stone passes and obstructs one kidney, the other kidney can pick up the slack for the couple days or a week or so until it passes. With one kidney, that cannot be the case. So this is something to monitor for. There is a theoretical risk of trauma to the solitary kidney. If that trauma is so severe it required a nephrectomy, then there would be no kidney left. In general, this is very low, and although patients are counseled of this, in the pediatric population, it generally is not considered a high enough risk to prohibit them from playing contact sports based on the recommendations. But of course, every case should be discussed with their physician on a case-by-case basis. So that's it. Life with one kidney, what to expect, what are the reasons for a solitary kidney, what the expected kidney function is with a solitary kidney, and potential risks, things to monitor for. If you made it this far, thanks for watching. Hit like, subscribe, leave comments below, share with your friends, and until next time.